name is Alexander Postalian, and this is another episode of Asked and Answered. I checked my labs and saw that my ApoB, which is short for apolipoprotein B, was elevated. What does this mean? Checking cholesterol is getting too confusing for me. I agree, it's getting complicated. And before I answer this, I want to take a step back and kind of go from the beginning. We know cholesterol is bad because it causes plaque deposition. It deposits inside the arteries and increases the risk of heart attacks and strokes. Cholesterol in the blood doesn't circulate freely. It circulates inside particles that we call lipoproteins because they have lipids and they have protein, and they are different. One of them is the HDL, or high density lipoprotein, which is what we call good cholesterol because it can prevent plaque deposition in the arteries. Another lipoprotein is the LDL, which is low density lipoprotein. That's what we consider the bad cholesterol because the cholesterol that travels there is more likely to deposit in the vessel walls. Now there's a little bit of a problem, okay? And now I'm getting into the specifics to talk about why apolipoprotein B is important. Cholesterol that we measure when we check your blood, and we get a number, LDL 120, is the total amount of cholesterol that's inside all your LDL particles. And we think that the smaller particles are a little bit riskier than the big LDL particles. So for example, if you have a cholesterol of LDL in the lab of 120, you could have few large LDL particles, or you could have a lot of small LDL particles. We could measure the sizes, or we could do something else, which is measure apolipoprotein B. And where does that come in? Because there's one apolipoprotein B per each LDL. So if you have a lot of apolipoprotein B with a cholesterol of LDL 120, means you have more smaller particles. If you have few or lower apolipoprotein B levels with the same LDL cholesterol levels, it means that you may have fewer larger particles. In essence, the higher the ApoB, the higher the risk in a more precise way than just measuring the LDL. And it's not just the size of the particles, but there's ApoB in other particles that are not measured by the usual lab tests. Like, for example, IDL, that are also what we call atherogenic. They can deposit inside the arteries. So measuring ApoB not only gives you an idea of if you have smaller or large LDL particles, which matters to some degree, it also tells you if you have higher levels of other particles that we're not measuring. So apolipoprotein B is a more precise measure of your risk than LDL. However, when we do clinical trials, and we like to make decisions based on clinical trials, not just on theory of what we think works and might be good for you, we measured LDL levels. So that's why we use that to guide ourselves. But if you want to fine-tune the assessment, measuring apolipoprotein B, or ApoB for short, is a good idea. Okay, next question. My testosterone level is normal, but my T-clinic tells me that I would still benefit from testosterone therapy. They also tell me that testosterone supplementation is safe for the heart. Is this true? Okay, we've seen a significant rise in testosterone prescription over the last few years. And there's been this question of whether testosterone is safe for the heart or not. Kind of anecdotally, we've noticed that sometimes if patients use excess testosterone, they can raise your blood pressure, it can change your lipid markers. There are some studies saying that it might increase plaque deposition in the heart. But recently there was one big study called the Traverse trial, where they took patients that had cardiovascular disease. They're risky patients. Some of them got testosterone, some of them got placebo, and it turns out that the risk of bad heart events was similar in both groups, meaning that it's considered to be safe. And that has been used to sort of say, hey, testosterone is probably safer than we initially thought. However, there are some important things to mention. In that study, testosterone was only given to patients that had low testosterone levels, below 300. And testosterone in real life is being used often in patients with normal levels or low normal levels, just to improve their symptoms of fatigue, which may or may not be caused by low testosterone. Then the other important point to mention is that the target level of testosterone that was achieved during the study, the mean was about 350 to 400. And in real life, we also see that patients receive testosterone and they're hitting levels that are much higher than that, in the 600, 700, 1000, which may make them feel better, might increase muscle mass, but the safety is still unclear. So what I will say is, if testosterone is used in the right conditions and aiming for normal to lowish levels, it's probably safe. And I know a lot of cardiologists don't like me saying this, because cardiologists in general, we have concerns about the potential side effects of long-term testosterone use. But I think it's reasonable to say that if you use it at low levels, aim for normal to low levels and avoiding these super therapeutic targets of above 1000, and it's unlikely to cause major problems in the short to midterm, at least. Next question. The calcium score test is useless and not advised by real doctors who are honest, since it only measures the hard plaque and not the deadly soft one. There's some truth to this, but now I want to take it back a few steps. A cholesterol plaque. Okay, cholesterol plaque forms in the arteries of the heart, and then over time it calcifies. And you can see the calcium on the calcium score. But before it calcifies, it is non-calcified. It is what we call soft plaque. We think that soft plaque is likely more dangerous than hard plaque because it's more likely to rupture. And when a plaque ruptures, that's where platelets attach to it, they clog the vessel, and they give you essentially a heart attack. So you might say, okay, well, if the calcium score only measures the hard plaque, then why are we even checking it? A couple of reasons. Statistically, okay, if someone has a high calcium score, meaning you have a high number of calcified hard plaque, you also have a high number of soft plaque that we're not measuring directly, but we know that it's associated with it. So, and we've measured it. We know that if you have a high calcium score, only checking the hard plaque, we know that you get more heart attacks and strokes than if you have a low calcium score. So you already have that part of the answer there. If we wanted to check specifically soft plaque, then you would have to get a more expensive, more involved test that involves the injection of IV contrast, which is a coronary CT angiogram or a coronary MRI. Those tests are not done routinely unless you have symptoms, meaning chest pain, shortness of breath, and we are concerned about something specific. A calcium score is used as a relatively inexpensive screening test for prevention. Again, high calcium score means you likely have also higher levels of soft plaque, and we know that it increases your risk of heart attacks and strokes, and it helps us decide when to start medication or not. So yes, the calcium score does not check the soft plaque, but it doesn't mean that it's useless. It is a good screening test. Now, if you have symptoms or a markedly abnormal calcium score with other risk factors, you can have a conversation with your doctor as to whether the other tests, like the coronary CTA with contrast or an MRI or something else, are a good idea for you.